Hey, Daniel, how's it going?
Hey, Evan. It is Friday. It is the end of a long week. I am very excited for the weekend and upcoming fall. How are you doing?
I'm doing all right. I mean, you've had a busy week stepping into an interim director role outside of your normal comfort zone. It's 6:30. Well, now it's 6:41 on the West Coast. So, I mean, you've been up and going for probably a bit, but I am um downing coffee. Hopefully, we don't have to take a quick break during this recording. So, um, can you believe it? We're on episode 17, automation in action already.
It's wild. It's coming to a soon conclusion of season two, so that's fun. We're starting to even get topics ready for season three. I also have two coffees here. I have an iced and a hot, so I'm ready for today's action.
That's awesome. Well, I know we're going to do a quick shameless plug to all you listeners. Daniel and I are looking for new topics for season 3, like you said, but we're also looking for new guests. So if you have a topic, want to come and talk about what your organization's doing that's fun and cool, or if you're early careerist and you want to talk about, what you're road mapping out and how you want to grow as an individual, we're happy to chat with you as well. So reach out to us via LinkedIn or our email, and we will take it from there. Should we get ready to jump into this episode, Daniel?
Yeah. To start out, I'll introduce our first guest today. Just as we're jumping into the hot topic segments. It is football Saturday, so I feel like I need to say that she graduated from the Ohio State University and started her career in 2003, holding various roles within the revenue cycle for 18 years before joining Allegheny Health Network as the VP of Revenue Cycle. Oversight in hospital and professional services, has some Epic background as well as a certified PB admin and claims builder. Thanks, Shawnda, for joining us this morning.
Hi, thank you for having me.
All right. Well, I don't think our second guest really needs a lot of introduction. I think this is their third time on the podcast now. And we've repeated a few episodes. So we'll give her, maybe it's her fourth because of that. She is an expert in project management and implementation. She leads our client success division here at Wilshire. Background in HIM coding in the mid-cycle. We pretty much lean on her for all HIM and coding major projects and keeping up in the industry. She's been partnering with AHN for several years now, I think at least 3, and helping them out with implementation. So welcome back, Jenn.
Hi, good morning. Thanks for having me.
We are happy to have you. Well, we're so glad to have you both actually today to join us on this journey that we've been on this year around AI and machine learning. It's been a wild ride.
Yeah, and for today's episode, automation and action, we'll start off with doing just like a little bit of recap and talking about what we've talked about this season. So we had colleagues on from Claim Capital where we discussed just like general fears about AI. And we had Chris from Janus Health join to talk about generative AI and some of the cool technology there. We've had Adeo Technologies as well for the coding world around machine learning and AI. So AI. I need to get like a tattoo or something, just show my interest, show my loyalty. But yeah, I mean, we've talked a lot about the good things and some of the fears, but let's expand on that today.
Well, and I think our expansion today is definitely around we're bringing in a location where all of our other conversations have been with the technology side of it. We're happy to have both of you guys here to get your perspective of, how's operations doing this in real life. So what are some of the fears that you guys are starting to tackle, just fears in general around AI, or even exploring that with your leaders?
So naturally speaking, folks are always fearful that we're going to replace them with robots, right? I'm going to lose my job. I'm not valuable here. Those kinds of concerns. And, my philosophy on it has been to just be very honest about automation and try to engage them in the adoption of it. So I like to say, we're doing this, but we want your help. you're going to have a job here. There's plenty of work to do. We all know that, right? So you're guaranteed to retain a meaningful role within our organization. And we want your engagement and your help. Help us identify things that are redundant, that you do over and over and over again. And, it always comes to mixed reviews, right? But I think the most important thing is just to be very upfront and honest and direct about your intention, but try to engage them in that. So that's just how I approach it. I don't know if it's good, bad, or in between, but I think being honest that we are going to do this, we want your help, at least lets them know that they're valuable to the process.
I agree. As we're trying to implement some of these solutions, I think that people are throwing, and have been for the past 3 years, throwing around AI and automation in very generic terms. Mm-hmm. And they act like it's going to be this silver bullet and it's going to be wonderful and solve all the world's problems. But when you're actually implementing some of these solutions and you're down in the details, you see the kind of effort that goes in behind trying to set it up, making sure it's right. With my HIM hat on, I always worry about sending payers more information than is necessary for payment. So I feel very strongly about not sending my entire visit if they really just want to see my pathology results because they're checking it, for a charge that the pathologist dropped. And so walking that line of trying to make it automated, trying to take the busy work out of a human's hands so that they can concentrate on more complex problems, because like Shawnda said, there is no lack of work in our work queues, right? And so, but also making it easy, but also not going overboard. And the implementation of it is a lot more detailed and nuanced than people would have you believe, I think.
Yeah, I think we're always walking that fine line, right, between what's needed and what's regulatorily required, the nice to have versus the want it all. So I know as we get into the second segment, we're going to talk a little bit more about areas of opportunities that kind of like what you guys are actually doing and walking that fine line with your teams a little bit more. But what are you guys exploring, or what are your teams engaging in other ways of automation, or even like utilizing automation, maybe not to do their work, but to do some of the checking or to do some of the evaluation, or just kind of out there, what are you exploring in general?
Jenn, go ahead.
Okay. I
Hot seat.
warned before the podcast started that I don't have a lot of time to do a lot of reading on things that we're not actually doing right now, but not out there on the weekends reading up on the latest and greatest, unfortunately. But I think one of the things that I'm kind of watching is, downgrades and takebacks are such a huge part of what you deal with from the provider or healthcare system side right now. And it can be very frustrating. And some days it feels like a fight. And so there are a lot of interesting things going on in terms of, people using different software and then, comparing DRGs and saying, no, well, our software got this DRG, but your software got this. And what are the algorithms or the nosology behind that? I worry a little bit about the data mining of sending, as I said before, way too much information over to payers. And we don't know what the result of that is going to be in a couple of years. Like, I love the idea of taking care of patients better because the information is there for Medicare risk adjustment and HEDIS quality. I love that. But do we know how that information is going to be used yet? I mean, I know it's not a lot different than someone from that organization or that payer coming in to, one of our facilities and looking at my longitudinal medical records for the past 3 years. But now they have that information at their fingertips and they have a copy of it, not just looking at it in the facility. So I worry a little bit about what's going to transpire in the next couple of years with all of that. I mean, there are good things, but I'm sure there will be some negative things as well.
One issue that we're experiencing is ED downgrades. So I think a lot of organizations have this issue, the Optum analyzer that payers are adopting, and we are working towards automating our appeals around that type of denial. We're looking at automating some coding. We have our imaging and radiology services outsourced right now, and our intention in the future is to bring it in-house so that we're all on Epic together. But we didn't have any automated coding solution for simple type services. So we are working on a pilot right now with a vendor. It's been very successful, and we are looking to fully implement and roll that out in the future. So that's something that we're looking at. And then one more thing that I'll mention is our what we call our E2 department. They have software that they can put on folks' computers, individual user computers, and try to find those redundant activities or transactions that folks are taking within their workflows. We haven't actually done that in RevCycle yet. I know that department has worked, I think, with HR and maybe supply chain, but that's something that we're looking at doing as well, because like I mentioned earlier, we do want folks to engage with us. We do want them to tell us, where they see opportunities, but sometimes when your head's down or in your day-to-day, something that you've done for years, it doesn't even like click that it's something that they should, speak up about. It's just ingrained in what they do. So we're going to maybe look at that solution to try to tease some of that out. Again, going back to it, the fear, is somebody watching what I'm doing, and that's absolutely not the intent. And there's there's some really great messaging around that so that folks feel comfortable. It's fully voluntary, but to help us with some of those type of automations as well.
Maybe to put a little bit different spin on this, and this probably, Shawnda and Evan, this is probably a question relevant for both of you. We're talking about, like, I think Jen said, it's a silver bullet. These are the golden goose. These vendors come in, they're like, here's a solution. Is the sales cycle and like the ROI that these folks are presenting similar to like bringing on other vendors? Like, what does that process look like? And I know like there's like an overall just like belt, like we're shortening our budgets a little bit. And so these are oftentimes expensive solutions. And I'm curious just like what your both experiences with like engaging with these folks who are like, here's this AI tool, or here's this new tool that's going to make everything better. And are they able to like put ROI in the same context?
Well, it varies from vendor to vendor. Some are very expensive, some are less expensive, right? And so some of them, I won't mention any names, it's just like eye-popping how much it costs, right? But then you have other solutions. It's somebody that you mentioned earlier that come in and, you're like, they really take your real life information, kind of test it out and give you the ROI. And so those are, of course, of more interest to me specifically when I'm looking at my budget, right? And then the other thing to mention is, there's software that you can obviously deploy in-house where you have folks build out your automation for you, which is much less expensive. So if you have that expertise, you can utilize that as well. So I am not always sold on the ROI presentations, and not always a huge supporter of some of it in the vendor space, but some others, they come in and they're like, hey, this is a lot less, costs a lot less, and we can do a lot more. And sometimes they sell you on it, and it's good.
Yeah, I fully agree. I think it's also looking at it like, what's the contingency component, right? Like, I am a strong proponent, even in when I'm doing interim work, and with my current client, I think I have like 6 RFIs out there right now that I'm reviewing and looking at. But even some of them, I'm like, no, what's the contingency base? Like, if I'm looking at a authorization component and notification of admission, what's the risk they're going to take there? If their system goes down, doesn't do it, yeah, they have SLAs and that's all great, but that doesn't mean that I'm not still going to get, my organization is still not going to get the denial factor or be financially impacted if their system goes down. So what's the financial risk that I want them to take? That's what I'm looking for with a vendor. And then in the AI or automation or machine learning space, how much of it are you going to give me for free? So like, are all my upgrades going to be free? Is the refinement of the rules when the rule breaks, or the health plan integrates something new that's going to actually shut down the rule from being able to work, or you need to update the bot because of the new regulations that have come out. Like, how much of that is maintenance or how much of that is going to cost us in the long run? I think those are things that we're all having to explore. And then at the end of the day, it really comes down to, are you able to put your solution in, or take my historical data and run it and then show me what I'm actually going to get, and let me process a few of those reprocess a few of those claims that way and see if I'm actually going to get it. So a pilot phase. And there are a few AI vendors out there, because they're trying to break into the market big time, that are offering kind of those, depending on the different spaces, that like free trial basis of things. I know of a couple coding vendors that have just presented to my clients, and they're like, one of them's like, yeah, we'll do 90 days for free, after we'll implement and then do 90 days for free to see if it works, and if not, then you guys back it out and it's fine. So I do think that, there are those elements out there that people they're trying to break in. But you also want the ability to self-control too, in some ways. So can you update a bot? And there are a few out there that are like, hey, we'll teach your team how to build the rules, build the bot engines, and then you become your own maintenance group on that. And if you want to explore and blow it up even more, then they come in with the team to help you recreate some additional items, and then your team does the maintenance portion of it. So
I think my biggest question is always, what's the IT lift, right? Because I'm sure that we are not alone in the fact that our IT team is very streamlined and short-staffed right now. And so, if we are going to need to have our IT team involved, I mean, we're probably, and it's a project that we haven't talked about yet, we're probably looking 6, 9, 12 months out as far as scheduling goes. And so it's not an immediate plug and play thing. So the things that are the most attractive to me, as Shawnda said, are the things that are, in-house, that obviously it's time and energy, but that we can build ourselves in our EMR, which is Epic, or the things that a third-party vendor comes in and says, listen, all you have to do is set up this one feed for us, and then we will take it from there. We don't need to engage your IT team. It's not 17 interfaces. It's not 14 different Clarity dumps of data, like that kind of stuff. Like, how do we make it easier on IT?
But it is a contract. So
yeah. Yep.
It can take 6, 9, 12 months too, right?
Right.
Yeah, that's so true. Or it could be like overnight and you weren't ready to implement, and you needed it. You were relying on that contract phase to drag it out a little bit into the next fiscal year. But nope, sure enough, it's hitting now. All right, let's take a quick break and we'll be right back.
Are you ready to unlock the full potential of your medical coding team? Look no further than Adeo Technologies, the leading provider of medical coding productivity solutions. With Adeo's Gemini Solution Suite, medical coders are empowered and complemented with cutting-edge tools and technologies. The Gemini Coder Platform, Gemini Autocode, and Gemini Coding Assist solutions work seamlessly together, creating efficiency and improving accuracy in medical coding. Say goodbye to tedious manual processes, cheat sheets, and memorization, and embrace the power of workflow improvements, artificial intelligence, and predictive coding. At Adeo, we believe in the collaboration between medical coders and artificial intelligence to create coding capacity that makes human coders more valuable to their healthcare organizations. Visit our website at www.adeo-tech.com. It's adeo-tech.com to learn why we love coders and how Adeo Technologies is transforming medical coding productivity one claim at a time.
Vine Medical serves a growing base of more than 800 active hospitals and health systems nationwide. Their best practices are hardwired through technology solutions, proven to help hospitals achieve sustainable top performance. Their well-published results include improving financial performance, physician and staff alignment, patient experience, compliance, and patient safety and quality measures. Learn more at vinemedical.com. That's VYNE medical.com. And we're back.
All right. So we're going to move into the next segment where we'll discuss our industry trends, out-of-the-box ideas, and topics to get you thinking. So again, our topic today, automation in action. Shawnda, in chatting about just like upcoming projects that you're doing and automation projects, we've talked a lot about in-house and like what can we do within our EMR, within Epic, within our project teams. And I'm curious, of that list of automation projects that you're working on, what are the most exciting things for you right now?
Well, one of the most exciting projects that we're working on at AHN is implementing mind chart messaging to the patient for high volume denials, the highest being coordination of benefits. So coordination of benefits denial can mean a variety of things, but typically, and the ones that we need the most patient engagement with are when you have to update your insurance for your coordination of benefits. Okay. So we can't, as a revenue cycle team, we can't really do much about that. We're relying on the patient to update update the payer. So, and there are thousands of these that come in, right? So a lot of the automation, does occur in Epic, which I'm always Epic first on automation, right? Jenn just mentioned using our tools that we have in-house that are not as costly. We don't have to, drag out for a long time. So what happens what we're working on is when the patient when the payer denies the claim for coordination of benefits, the denial comes in, posted in the system. We write rules around the payer and the denial type, or our RMC code. And then that kicks off one of three things, right? So the first thing would be, okay, if the patient has an active My Chart, send a message, and it's like a canned message to the patient directly. And then from there, they can respond, and it goes to a pool within Epic, and the end user can then interact with the patient. You can, talk via chat, basically. And it's really nice because the patient can then, if it's maybe an insurance update, maybe they don't have that insurance anymore and they need to update it, they can take a picture of their insurance card, upload it, and then we can add it to the patient's chart and update the insurance and get everything built out. So it's a nice option, especially for folks that are more tech savvy, right? Myself, that would be the option that I like to take. So I have my phone in my hand all the time, right? So I just want to update things and send it on its way. So if the patient doesn't have an active mind chart, then our next option would be to email the patient and say, hey, can we need you to engage with your insurance company. Can you, work with them and let us know, what's going on. And then the third option, if we don't have an active My Chart, we don't have an email address, the third option then would be to automate a letter, send it via snail mail, which I know when I get those letters, they go in the trash can, especially if it's like, you owe us $5,000 if you don't respond, whatever, So that's why we want, we have this hierarchy, how we want to connect with the patients. Now, I'm not saying that the letter is not valuable, because it is for folks who, maybe aren't as tech savvy. So we need that option to be in play, and you can fully automate this. And then once the action is taken, it defers the denial in a work queue, and it's a no-touch process. And when you have thousands of these kind of denials a month, literally thousands for millions of dollars, it adds up quickly, right? There's a lot of time and effort. So if you can automate that first pass, it's really a great win for your organization. The other thing that I want to just plug quickly is that at AHN, we're working on integrating our PB and HB, hospital and professional billing teams, so that it's just one hit to the patient, right? One connection, one touch. Historically, for a lot of organizations, and still today, those teams are completely separate. They're doing their own things, and the patient's getting hit up on both sides. So we're centralizing and or integrating those teams, and then we want to combine that automation. That's kind of second phase. Right now, we're on the first phase of just getting the automation up and running, which, as Jenn said, it could take 6, 9, 12 months, depending on resources and those sorts of things. But it's a really neat way, I think, to encourage patient engagement and to reduce the touches on. And this work is redundant. It really is, because there's not much we can do other than say, please help us.
So, Shawnda, are you guys looking for second touch? So, let's say patient doesn't respond to any of your outreaches. Are you looking at like doing an auto dialer automation solution where like it then pushes defaults automatically in Epic to a self-pay collections and hits that work queue, and then leveraging like an automatic auto dialer to call out to the patient about coordination of benefits, where then they can push a button and it's like, oh, now I'm connecting you to a live rep to talk you through it.
We haven't gone that far yet. Just simply, we have resource constraints as well of phone calls, and we're trying to reduce those, and just all that kind of stuff. What we are exploring is if we do not get a response. And the nice thing about the MyChart message, if the patient reads it or not.
Right.
So that's kind of an added bonus. And you can, through all this activity, you can kind of report on it. So that's nice to see, what steps were, what actions are occurring. But what we are going to do is we re-ping the payer. I'm so sorry. After X amount of days, we're going to re-ping the patient. So we know that they haven't read it or responded. So we're going to ask them again for that information. Once it goes through, all the days and the cycles and everything, then, it's what steps do we take from there? So I think, we do reach out on high dollar cases to the patient to try to get them engaged and with that phone call, but we haven't gotten to the piece yet where we've automated it fully through to that. I'm sure we'll get there eventually, but that's connecting various teams and departments, and but would be a great option for in the future.
Cool. All right, Jen, I got a question for you now. So with all the current work that you got going on at AHN, I know that you guys are exploring payer platforms. Can you share a little bit more about like the details on the project, what AHN's thinking about how they're going to initiate it and then leverage it, current state, leverage it, and then kind of maybe what they're thinking in the future to leverage payer platforms for?
Yeah, payer platforms, so buzzy right now, right? Everyone's talking about it.
I know. I my client too. They're like, "Can we do this?" I was like, "Can we do it as a group versus 5 different locations?"
Yeah. So interesting enough for us, it kind of started off in the managed care space because payers are starting to ask for payer platform as part of contracting. And so we are in a situation with 2 payers on the same timeline that we are implementing before the end of the year. For those of you that aren't familiar with payer platform, it's basically where a payer purchases their own instance of Epic. So they in effect become like an Epic customer. And so they use technology very similar to Care Everywhere. So how we would share information with another healthcare system so that the patient has that, so that you have, continuity of care for the patient with Care Everywhere. It's very similar to that type of technology, but it's done between the healthcare system and the payer. And so there's many components of payer platform. What we are focusing on first is what they call clinical document exchange and ADT notifications. So the idea here is basically that if the payer that is live with payer platform is my primary or secondary coverage, they are going to share a subset of for that visit. They're going to share a subset of my medical record, not the entire legal medical record, but a subset of it, kind of what you would share in a Care Everywhere situation with the payer for that visit. They also will notify the payer via what we call the ADT notifications when I'm admitted in an acute care setting. So the payer is going to know that I've been admitted to the hospital, so that, in the future, those coverages can be checked, authorizations become easier, that kind of stuff. So my biggest interest in this, so when we first started talking about it, we were a little bit hesitant on the benefit to the healthcare system. So what a lot of people started off doing was sharing that kind of, what I said, the clinical document exchange information with payers, helps the payers retrieve the information that they need today to do what I call a longitudinal medical record request. So for things like Medicare risk adjustment or HEDIS or quality, it helps them in that way, which is great for the patient, great for the payer. How does that benefit us? right? Like, how does that benefit and reduce our administrative costs? And so the other piece of sharing that clinical information is in the case today where we receive, I'm going to use the term letters very loosely. When I say letter, I could be talking about emails with PDFs, something that's sent to Availity, our RCM, something that is sent to a payer's portal that we are expected to download ourselves, faxes, etc. When we receive those today for payment integrity or audit purposes, that is a manual workflow for us with a huge administrative cost of releasing those records. And so the other piece that will be beneficial from a payer platform perspective is that in those cases today where those payers would be requesting that information from us, payer platform has functionality, they call it additional documentation request, where that piece can be automated as well. So we are looking at, from one of the payers that we're implementing, from a Medicare risk adjustment type of thing, we're talking 15,000 requests per year that we hope to eliminate. From, I don't have all the numbers for the payment integrity audit yet, but from one particular payer for a 6-month period, there were 1,000 medical record requests just in the clinic space. So not even talking facility. So what we're trying to do is eliminate all of that type of manual work, and that will be a huge administrative cost savings for us. So we're talking, our mail team, our HIM team, our third-party vendor for release of information, saving costs on all those fronts.
Yeah, it's interesting with payer platforms. As I shared, my client has been approached by multiple players as well around implementation of it, and we're taking a little bit different of spin. Initially, we're looking at it from a continuation of care and a prior authorization request platform is what the payers are wanting to leverage it initially for. So, going in and saying, okay, auth's been requested. Now the payer goes out through payer platform and they auto pull the clinical records associated to being able to approve it versus us having to upload that. And then once the patient's in-house, instead of case management and utilization review management having to fax records every day and pull things and make phone calls, the payer is just able to go directly out into that platform, look at it, take whatever their current inpatient scoring is that we have in our platform as well to see that, like, oh, yep, they're meeting the agreed upon score rate percentages and ratios, and here's that associated documentation that we need. So that's kind of how they're initiating it as well. What I had the pleasure of talking with one of the Epic BFs yesterday, and I love where they're headed, where eventually it's even going to be, processing the claims, and we're no longer, instead of like doing direct claims from Epic we're processing the claims through payer platform and leveraging it more like a tapestry type model, and being able to instead of having to do claim attachments or having to fax records or having to try to do all of that, just having them go directly out and pull what is needed. But like you, Jen, my concern is, how do we isolate what those individual teams at the payers are able to access or leverage? I mean, I know at my prior organization, prior to joining Wilshire, we had several payers that had direct connect into Epic. So our expectation was they were pulling those records themselves. We gave them the full medical record access, but then at the same time, how do we know what they're pulling? And we had to create automation. We had to create bots essentially to go and like scan what are they actually grabbing out of the record and seeing. So, that I think will be interesting to see is through payer platform, how can our compliance departments look at seeing what the payers are pulling? What can our revenue integrity departments go out and see what they're pulling as well, so that we can start to determine and decipher, like, how do we do more denial of prevention? Are they getting too much information? If I'm looking at like a TPL work comp case, yeah, we run a pregnancy test on every patient when they come in through the ED if they're a female, right? But they're not entitled to know if it's positive or negative in those cases. What they're entitled to know is simply just what's associated with that accident, but we're doing it for how do we do the next course of step, but those records aren't theirs to know. So how do you ensure that they don't get that part of the clinical note or the lab test? I think those are the parts that we're all still exploring with payer platform, at least what I'm seeing people still exploring. So
is this whole lift for payer platform on like the IT team as well? Like I know, Jen, you mentioned earlier, like that your first question is like, what's the lift on IT? This sounds like a lot. Am I understanding that?
Here's my take is that both the payer and in this case, the vendor Epic will tell you that it's a 4 to 6 week project. What I will tell you is that at most healthcare organizations, if the payer and Epic tell that to me, I'm tripling that amount of time in my head. And that's being generous. And it's because when we're talking with the payer and we're talking with Epic, their concerns are not the same as our concerns. Our concerns are making sure we make the correct decisions so that we are not giving more information than is necessary for payment. We have a lot of privacy, HIM compliance people on our committee. We are dedicated to making sure that we are making the correct decisions and not giving, way too much access and way too much information. And there are a lot of very technical decisions that need to be made. There's a whole checklist. And so I would say the lift is not necessarily that high on the IT side, but the lift is behind the scenes of telling IT what to do. So IT is not going to make the decision about which departments are we going to restrict from sending over? Like that's not IT's decision to make. Once we decide that on the operations side, IT can do that. It's not that big. So Epic and the payers are correct in saying like, if all the decisions are already made and you know exactly what you're going to do and you've read, spent 4 hours reading all this documentation and all this stuff, then yes, the IT lift isn't that big, but there's a lot of prep work. So though we just actually kicked off our project with IT this month in September, we've been working on this project since May.
Now, one thing to remember about Epic Payer Platform is that it is not one size fits all. The payers pick and choose which, aspects of it they want to implement or work with you on. And so it's, when people start talking about the implementation of it, it's like, everybody's like all excited that, it's going to streamline everything and it's going to be this wonderful product. And I'm not saying that it's not a great solution, but it's not the same for every payer, and what they're focused in on and their benefits from it may not be the same as your organizations. So that's always something to think about, at least for in the current state, when you're looking at Epic Payer Platform.
Well, and I think that's just it. I mean, I was talking with a payer yesterday and they're like, no, we only want it for this prior auth portion. And I'm like, but that's not actually going to help our organization. Like,
Right.
What's going to help our organization if we could leverage it versus claim attachments? So speaking of claim attachments,
And claim attachments always seem to be at the bottom of the payer's list.
right. Yeah, like no, we don't want to do that. Like, no, just send us the records so it could that claim can process for another 90 days and age out your AR.
That's why people start throwing around ROIs on this. And it's like, whoa, hold on.
Yeah.
We really think about that.
So Jen, I know that speaking of claim attachments, I think that's also on your guys' horizon there at AHN, and you've been tasked to help support with that implementation process too. So what are you guys doing? How many payers are you guys trying to bite off at one big bite? Or are you going small and multiple little small spoonfuls?
So Shawnda and I feel very strongly about claim attachment.
I'm very passionate. Can we extend the time that we're going to talk here today?
You told us you had a hard stop.
A lot of work in this space. So it's yes, I'm very passionate about it being a no-touch process because you can achieve that.
Yeah. And so I think, we found ourselves in a spot where when we started this year, our Epic Refuel project, our numbers for claim attachments looked decent. We were getting something out the door. But But when we were able to do a little bit of a deeper dive, we found that maybe what we were getting out the door wasn't necessarily what the payer was asking for that particular date of service in the PB world, for instance. So we started with kind of retooling our PB claim attachments, and that's where we're working on right now. And so again, with my HIM hat on, I would say that of all the pieces of functionality that I have worked on in Epic over my 20 years of working in Epic, I would say that claim attachments is one of the trickiest. It is because PB claims and HIM release of information have literally never spoken together before. They don't know that each other exists. Or like, what is this team over here doing? Like, it is not an integrated team. They don't typically work on projects together. And so blending those worlds of, here's a PB claim edit, this payer needs an attachment. All right, let's automate this as much as possible, but then teaching those end users, okay, well, for instance, the date that a charge post for pathology is typically 5 days or so after the date of service. So Epic isn't smart enough quite yet to be like, oh, it's the pathology charge that you're looking to send the attachment on. Let me look back 5 days and then grab that pathology result and meld them together. So, we're working through all of that process of basically like, how do we teach those end users, like, who are used to having to go to chart review, manually print out, create a PDF, send it through mail, fax it, what have you. How do we teach them how to, okay, let's make it so easy that they can just jump into release of information, grab that info and send it electronically so that it goes straight to Availity. And so what we're really focusing on in the PB world is workers' comp and then auto. And the idea is that once we get these reports right, and my HIM hat on, right, I don't want duplicate results. I don't want, discontinued orders. I want them to be perfect and I want them to be short and I don't want them to be 17 pages, that kind of stuff. So as we get each of these encounter types kind of fixed, the idea is that it will be easier to kind of go through each of our payers. And I think what Shawnda is really excited about is the new functionality that we'll have in Availity for electronic attachments.
Are you also thinking at leveraging, from the perspective of claim attachments, I look at it in my funnel lens, right, of saying, hey, okay, so payer X, we know that at X number of dollars, they always need an itemized statement. So how do I leverage that? But, I also know we leverage our CDF rules within Epic to strip codes, do all of these things. So I that's the part that we're struggling with at looking at claim attachments. We know we charge for it, but we strip it at the claim and it rolls up into, on an inpatient into the DRG or into the revenue code component. So that's my other portion of like, how are we going to tackle that, manual stripping of certain information out of it as we're doing claim attachments and getting that to automate. And that's what, at least one of the locations I'm working with right now is struggling with, is that stripping portion, because they did finally get like, hey, on these, the health plan was great. Like anything over $50,000, we're always going to ask for this with this certain diagnosis type. So we can leverage that for claim attachments, but how do we remove the noise, that they don't need, and the parts that are not a standard clinical record that you can clean that out from the ROI perspective?
We haven't really gone there with the HB detailed claim builds yet. I know we have bots today that send with medical records for some vendors that send the detailed bill. And so I'm assuming we're sending just the whole detailed bill, but I don't have a lot of insight into that yet.
Cool.
Well, as we're looking to wrap up here on today's episode, I got a question for us here. Just to think about, we've talked a lot about different automation actions and different projects that we're working on. What did that prioritization look like? Like, where were you, or who was part of that committee or that decision to be like, this is what we're working on first and second and third, and here's kind of our pool of projects to work on? Is that something that you all have gone through and thought about before? Or is it just like as it comes up?
Yeah, well, we need to get there. I don't think we're quite there yet. So collaboratively, we look at our projects and where can we automate and what can we do, and which areas have the capacity right now to focus in on that. But creating a automation prioritization group is probably we're looking at that in our future, because to your point, you can't work on everything at once. And you don't want to work on something that has like a lesser ROI, right? So you really have to, pay attention to those types of things. Right now, we are looking at it in terms of, heavy user touch, or, dollars associated with that automation. So.
All right, let's take a quick break and we'll be right back.
There are thousands of medical offices and facilities across America, each navigating through changing regulations and reimbursement models while striving for positive patient experiences and outcomes. A common element in each of these facilities is patient access, the front line of both the revenue cycle and the patient experience. Though diverse in facility size and geography, patient access professionals unite around a common purpose: enhancing the overall patient experience to increase patient satisfaction and outcomes. Through it all, one organization is there to educate, connect, inform, and pave the way toward the future of patient access. The National Association of Healthcare Access Management recognizes the changing role of patient access professionals and their increased importance.
Claim Capital is a team of ex-Epic staff focused on preventing denials. Instead of showing what was denied, which is the standard for other solutions available today, Claim Capital pinpoints why claims are denied. By training machine learning models on an organization's claim and remittance data, Claim Capital can identify the causes of denials and recommend changes in EHR build or workflows to prevent them from happening in the future. With a completely HIPAA-compliant infrastructure, no software implementations, and a zero-risk pricing structure, organizations can quickly and safely recover lost revenue.
And we're back.
All right, so we're just going into closing remarks here. And as we've kind of transitioned recently on the podcast, we have a lot of early careerists and wanting to share about what our industry is. I'm curious, just for Shawnda and Jenn, just for the both of you, if you can leave our listeners with a major professional accomplishment that you're proud of, just as obviously you all have a plethora of experience. We're curious what you have in store for us.
Something we've accomplished in the past, or something that we're working on for the future?
You can go either direction.
Oh, wow. Jenn, I'm going to let you go first. I didn't, I got to think about that one for a minute.
I guess for me, not one specific accomplishment, but as a consultant, I'm always very proud when I can work on a project for a customer that they've said, we've gotten 7 people in here and they've tried to do this project and no one's been able to do it. And, you've been able to accomplish it. And so I pride myself on being able to work on integrated projects that are kind of tricky, that are, involve several different teams. They involve operationalizing a process, working with training, doing what I call like workflow PR. If the workflow may exist and work in Epic or whatever system, but unless all the users know about it, it's not worth anything to anyone, right? And so I think that I pride myself on being able to work on projects like that, and being able to be successful at them. So that's probably kind of what I pride myself on the most in my career.
I think what I would have to say is that I started in healthcare in an entry-level position. In 2003, I started in a charge entry position, and I didn't know healthcare at all. I didn't go to school for healthcare. And as the years progressed, as I learned more, I was promoted along the way and learned more and more and more about revenue cycle. And now I'm kind of nerdy about it. But I think that having that experience coming in at the kind of the ground level and working your way through, you really, get your hands on everything along the way. And I think that that has been so beneficial to me in my role today, and I learned how to, I had to evolve as a leader, and I had to learn as I went along. So I came in at the ground floor and worked my way around. So I think that I take a lot of pride in that.
Awesome. Well, thanks both for joining us and season 2, episode 17, Automation in Action. Jenn, I know folks can probably reach out to you on our website, but for Shawnda, is there a best way for any listener to reach out and connect with you?
Yeah, you can. I'm on LinkedIn, so you can connect with me that way, or via email, I would imagine.
Your email shows on like your little face icon in Zoom for anybody who goes to our YouTube channel.
Or it's just a reason to go to the YouTube channel. Please listen to 45% of the show. No. All right. Well, I think that's it for us today, everybody. We will be back with episode 18 in a couple weeks and talk to you later. Bye-bye.
Thank you.
Thanks.
Bye.
If you liked today's episode, continue to join Wilshire Wednesdays.
You can follow us on LinkedIn or Twitter at Evan_Wilshire. Daniel can be followed at Daniel_TWG. Wilshire Group at TWG Health. On Facebook at the Wilshire Group or on Instagram at Wilshire IT Revcast.
Remember, if you prefer to watch, come check us out at the Wilshire IT Revcast YouTube channel.
If you have an inquiry, want to share your thoughts, or get additional information on today's episode, email us at WilshirePodcast@thewilshiregroup.net.
The best way to support this podcast is to review, rate, and subscribe. See you next time.
Bye-bye.
The Wilshire IT Revcast is hosted, produced, and engineered by Evan Martin and Daniel Bianchini. It is executive produced by Gretchen Case, Hank Smither, and Spencer Thielman. The Wilshire Group. Experience you can trust, results you can count on.